औज़ुबिल्लाहिमिनश्शैतानिर्रजीम बिस्मिल्लाहिर्रहमानिर्रहीम अर्रहमान अल्लमल कुरान खलक़ल इंसान अल्लमल बयान। आज आपके पास काफ़ी दिनों के बाद हाज़िर हो रहा हूँ और आज हम विल लर्न द स्टेप वाइज ABG's अंडरस्टैंडिंग. It is based on systematic approach to the ABG's interpretation. So to start with the normal values, the pH ranges from 7.35 to 7.45. Partial pressure of carbon dioxide 35 to 45 millimeter of mercury, bicarbonate 22 to 26. NN gap is 12 plus minus 2 milliequivalent per liter. In step 1, check internal consistency. Use the Henderson-Hasselbalch equation, which is H is equal to 24 into PaCO2 divided by bicarbonate. The approximate relationship is pH if 7.40, then hydrogen ion will be 40 nanomole. If pH is 7.30, hydrogen will be 50 nanomole per liter. If pH is 7.20, hydrogen will be 63, and so on. The mismatch between pH and hydrogen suggests an invalid ABG sample. Step 2. Determine acidemia or alkalemia. If the pH is less than 7.35, it is acidemia. If the pH is greater than 7.45, it is alkalemia. Remember, a normal pH does not exclude a mixed acid-base balance disorder. Step 3. Identify the primary disorder. In respiratory disorders such as respiratory acidosis, the pH is decreased, whereas the PaCO2 will be increased. In respiratory alkalosis, pH will be increased, whereas PaCO2 will be less. In metabolic disorders such as metabolic acidosis, pH will be decreased and bicarbonate will also be decreased. In metabolic alkalosis, pH will be increased and bicarb will be increased. The rule is pH and PaCO2 move in opposite direction, then it's a respiratory disorder. If pH and bicarbonate move in the same direction, it is a metabolic disorder. Step 4. Check expected compensation. For metabolic acidosis, this is a Winter's formula. Expected PaCO2 is equal to 1.5 into bicarbonate plus 8 minus 2. In metabolic alkalosis, the expected PaCO2 is 40 plus 0.6 into rise in bicarbonate, which we can find by subtracting the total bicarbonate from the normal bicarbonate. In respiratory acidosis, in case of acute, bicarbonate increases by 1 for every 10 mm mercury rise in PaCO2, whereas in chronic bicarbonate increases by 3.5 to 4 milliequivalent per liter for every 10 mm mercury rise. Respiratory alkalosis, in acute cases, the bicarbonate decreases by 2 milliequivalent per liter for 10 mm mercury fall in PaCO2, whereas in chronic bicarbonate decreased by 5 milliequivalent per 10 mm mercury fall. Observed compensation is not equal to expected compensation, then you must go for the mixed acid-base disorder. If it is the observed compensation is equal to the expected compensation, then there is a simple disorder. In step 5, calculate the anion gap. Anion gap is equal to sodium minus chloride plus bicarbonate. Albumin correction, add 2.5 milliequivalent per liter to the anion gap for every 1 gram per deciliter decrease in serum albumin below 4 gram per deciliter. Osmolar gap. If high anion gap metabolic acidosis with suspected toxic ingestion, then check the osmolar gap, which is equal to measured osmolality minus calculated osmolality. A high osmolar gap suggests methanol poisoning, ethylene glycol poisoning, or toxic alcohol ingestion. Step 6. Calculate the delta ratio. So delta ratio is equal to delta anion gap, which is the difference of anion gap and the delta bicarbonate. Delta ratio is equal to anion gap minus 12 divided by 24 minus bicarbonate. It is interpreted as if it is 1 to 2, this is a pure high anion gap metabolic acidosis. it is less than 1, there is concurrent normal NN gap metabolic acidosis. It's 2, then there is a concurrent metabolic alkalosis. Common causes of high NN gap metabolic acidosis include respiratory acidosis, COPD, asthma, CNS depression, neuromuscular disorders, obstructive sleep apnea, hyperventilation, respiratory alkalosis, anxiety, pain, sepsis, pulmonary embolism, pregnancy, liver disease, hypoxemia, metabolic acidosis. The mnemonic is mud piles or gold bark. M for methanol, U for uremia, D for diabetic ketoacidosis, E for ethylene glycol, S for salicylates. So normal N-gap metabolic acidosis is in diarrhea, renal tubular acidosis, acetazolamide, ileostomy, metabolic alkalosis, vomiting, NG suction, diuretics, hyperaldosteronism, volume contraction, and excess bicarbonate. ABG golden rules are always use a systematic approach. No matter what, always follow the systematic approach. You must after that calculate the compensation. And if the albumin is given in your question, do correct the NN gap for albumin. And if there is a high NN gap, then calculate the delta ratio. And always interpret ABGs in the clinical context. So you can give me your feedback on the number, and I pray that may Allah bless you and Allah help you. So see you next time. For any questions or queries, contact me on this number.